We're going to get started on time, so if you could find seats, that would be great. We wanted to start with a couple of announcements, and then I wanted to say a few things about the class in general. So first of all, welcome. Thank you for being here in N245A, Clinical Prevention and Population Health. I'm Mandy.
I'm Mary.
If you watched the intro video, you got an introduction to us. And I want to say just a couple sort of housekeeping things. Make sure to look at the intro video to read through the syllabus and let us know if you have any questions. Make sure you look at your curriculum if you're taking this for 1 or 2 units. If you don't know, look at your curriculum. The 1 unit students are going to be the peds neonate students pretty much, and then everyone else will be 2. If you have any questions about that, look at your curriculum, talk to your advisor. We also have office hours from 12 to 1 every Wednesday after this. If that doesn't work for you, I know there's an independent study group that a lot of people are in from 12 to 1. So if it doesn't work for you, we'll be available also at 1. You can email us, let us know what time would work for you if you have any questions. But please make use of the office hours from 12 to 1 if you have questions. And then I also wanted to take a minute to introduce Dr. Caroline Stevens. So we are in 245A, and this course is, I'm using the lapel mic because it makes me feel cool, by the way. Not for any particular reason. So Into 45A covers weeks 1 through 10. And so this is really looking at the social determinants of health, and clinical prevention aspects. So how you apply that to the care of individuals. And then Into 45B, Caroline can talk a little bit about Dr. Stevens teaches that part of the course, which actually runs weeks 6 through 10. And so I'll let you introduce that part of the class, and we've been trying to coordinate things a little bit better this year, and so just wanted to introduce.
Sure, yeah. Thank you. I'm excited to see all of you today. As Mandy said, my name is Caroline Stevens, and I'm going to be with you the latter half of the quarter. So while this class is really focused on kind of population health determinants, social determinants of health, et cetera, this is kind of giving you the 30,000-foot view of why is it that the issues that you're seeing in clinic, like what is it that you need to do as a clinician to now, in my class, advocate for change. And N245A used to be in winter quarter, and B used to be in the first 5 weeks of spring quarter. Unfortunately, we didn't have any control over them being now offered concurrently, but we are taking the feedback that we've received from students and trying to really fundamentally change and make them more closely linked. And so I have completely gutted what we previously did in B. That's why the syllabus isn't yet up on the CLE, but it will be soon. But it's really kind of taking what you're learning in this class, and your paper here will then be the background and significance for your paper in my class. And the paper in my class actually isn't a paper. It's a letter to an editor or an op-ed piece. So it's kind of giving you skills as an advanced practice nurse to kind of advocate for population health change. So that's just a little bit. I'm excited to have you all in 5 weeks.
Okay, so the outline of this class is that Mary is going to give a really brief intro, and then I'm going to talk about how we are going to apply population health concepts in the clinical setting. And then we're going to take a really brief break and dive into some of the more, intense content around talking about looking at population health data and the background that you need in order to look at that data. And so in the past, it's been an online module, and we just felt that the way that it was put together didn't really, people still had a lot of trouble understanding it. So we wanted to actually provide that content in class so we had room for discussion and room for people to ask questions. And so before I hand it over to Mary, the last thing I want to say is that we in this course are going to talk about the social determinants of health a lot. And undoubtedly, we're going to have a lot of complicated and in-depth discussions about those things. And it's hard to have a conversation about all of the stuff that happens outside the health system, because really only 20% of health outcomes are related to clinical care that we provide as clinicians, right? Everything else is outside the health system, and we're going to talk about that. But it's hard to talk about that without talking about the larger social structures that are at work here, and that undoubtedly will lead to some conversations that might include things about race, might include things about gender, about some disease processes that might be stigmatized. And so we just want to make sure to let you know that we are open to discussion, that we will always call the class back to having a respectful discussion, and also to make sure that we bring it back to our learning here, right? Because in order to learn and grow as clinicians, we have to address these issues of social determinants and these issues in the greater social structure. So we just wanted to lay that out there, acknowledge that that's there, and let you know that we will be having discussions about those things. And yeah, that's about it. I think I'm going to hand it over to Mary now.
Can you guys hear me with it down here? Yeah? Okay. All right. I'm going to start off talking about what population health is and why it's important for advanced practice nurses. I'm going to start with a couple of stories. The first one people refer to as the parable of the river. So there's a group of people out on a hike, and they come to a river, and they see there's a small child in the river. And so one of them dives into the rapids and saves this child and revives them. And then they see another child in the water. And so another one jumps in, saves the little kid. And this group of hikers keeps seeing more and more children coming down in the rapids. And so they keep rescuing these little kids, but they're just getting exhausted because they keep having to swim and, pull these kids out and revive them. And after this goes on for a while, one of the guys starts running up the side of the river. And one of the guys that's still in the water trying to save a kid looks at him and says, "Where are you going?" And the guy says, "I'm running upstream to see why all these kids are falling in the river in the first place, to see if I can fix the problem up there." And so that story gets to the type of thinking that's often used in public health and population health, where you're looking upstream, you're looking at the root cause of problems and trying to address things on the systems level, instead of waiting for things to happen and then trying to address the consequences after people are already sick and there's already been negative impacts of a disease or whatever health condition it is. To contrast that, the next one is the starfish story. So a couple of people are walking down a beach, and there's tons and tons of starfish that are all washed up on the beach, and they're all drying out, they're all dying. And so this one guy keeps throwing starfish back into the ocean. And the other guy turns to him and is like, "What are you doing? You're not going to make an impact because there's thousands of starfish and you're only one person. You can't throw that many starfish as an individual back into the ocean." And the guy looks at him and he reaches down, throws another starfish back. And he says, "Well, it made a difference to that one." So that story is kind of showing the clinician perspective of that really matters. Direct clinical care is really important. When you're out there treating individuals, that is definitely really important work, and we need people to be there helping individuals. But it's important to have both clinical care and population health, where people are also working on systems level change and working to address the root cause of problems. So those two are different, but it's important to remember that they're both necessary and really important. Does anybody want to read the definition of public health for me? Any volunteers? Okay. Thanks. So I think that's a really great classic definition to come back to of public health, because I think that the theory that grounds a lot of this is in working to change the social structures that make people ill. And I think that definition does a really good job of explaining that whole concept. Public health has been around for a long time, but then population health is actually a pretty new term. So population health is kind of a newer field, and there's a lot of different ways of defining it, and there's actually a lot of controversy in exactly what population health is. One way of looking at population health is through a public health lens. So looking at social determinants of health, looking at big picture systems, so looking at policy and things that impact people outside of the healthcare system and how that impacts the health of groups of people. And then the other way of looking at it is more tied to healthcare. It's within a lens of the medical model. So looking at like the UC Health definition down there, that's kind of a slightly narrower scope, and it's more tied to reimbursement models. So for example, like looking at how an HMO impacts the health of the population that HMO serves. So that's really important too, but it's a little bit narrower in scope. So kind of like with the parable of the river and the starfish story, these two definitions are a little bit like that because the first one is really broad, and then the next one, it's more focused on healthcare systems, so it's a little narrower. And a little bit later on, Mandy will give a couple examples that do a good job showing kind of the latter definition, so working within healthcare systems to create change. I wanted to compare the difference between how we measure health for a population versus for an individual. So you all are very familiar with working with individuals. So you might look at someone's blood pressure or hemoglobin A1C. But when we're looking at a population's health, we often use measures like life expectancy or mortality rate or fertility rate. So it's analogous, but it's on a population scale. And then how we measure the impact of disease for an individual, we might look at their lab values or if their symptoms are progressing. But if we're looking at the impact of disease on a population, we often look at outcomes measures like years of potential life lost, quality adjusted life years, disability adjusted life years. So you can see that in all these ways, it's similar, but we're just looking bigger picture when we go to population health instead of individual clinical care. And then how we measure success for an individual, we're looking at improved health of that person versus for a population. And an important point about this is how we measure success for an individual is based on that individual's goals of care. So for example, if you have a 90-year-old patient who is at the end of life and their goals are palliative care, you're going to work with that individual patient to work on improving their quality of life with the remaining time that they have left. So it's the patient's priorities. And similarly for population health, a lot of the time we need to talk to the community to find out what are their priorities. What does the community want? So in population health, we're not going in as outsiders from a community and saying, here's what you need. We're listening to them. We're getting input from the community and letting the community's culture and priorities guide and drive our population health interventions and programs. I wanted to go over briefly the current state of the United States healthcare system. I'm sure you're all familiar with a lot of this, but if we look at health outcomes compared to other countries, when we look at infant mortality rate and obesity prevalence and life expectancy at birth as some examples, you can see the United States is really not doing very well, especially when compared to other higher income countries. And that relates to like our current approach is not working very well at actually improving the health of the population of the United States. There's also a lot of disparities. So I chose this slide just to point out that in population health, we're working to reduce health disparities. We want to try to get rid of these gaps between different subpopulations. A disparity is a difference in health outcomes between subsets of a population based on characteristics such as socioeconomic status, race, sexual orientation, gender identity, geographic location, etc. And inequity is a difference in health between and within countries. So again, we're working to try to reduce these with population health interventions. And then this is showing that in addition to race and ethnicity, income is also important. So a lot of people don't have access to healthcare because they can't afford it. The cost is just too high. And this is even after the Affordable Care Act, that a lot of people still are having trouble affording all of the healthcare that they need. We are spending a lot of money on healthcare, even though our health outcomes are not very good. So you might look at that and say, well, why is it that we're spending more per capita on healthcare than any nation in the world, and yet we still have these poor health outcomes? One reason is that healthcare actually has a pretty minimal influence on health. I think it's common in the United States to think that health and healthcare are synonyms, but they're really not. Healthcare is a little slice of health. And inequities, I mentioned, and then we also have this focus on treating disease. A lot of our healthcare resources are currently not directed towards health promotion and preventing disease. So a lot of our current healthcare system is more geared towards waiting for people to develop conditions and then treating them once they become sick. The green arrow is showing, again, that healthcare is just a little portion of what actually makes people healthy or not healthy. And the social determinants of health are what we're going to talk about a lot in this class. It's all these different factors that influence the health of populations and of individuals. So a lot of these are factors that you wouldn't traditionally think of as being tied to health. They're not things that are within healthcare. For example, like housing, transportation, the built environment plays a big role in health. The environment is really important, but that's something that the traditional healthcare system usually doesn't spend that much time talking about or working on interventions to improve. The socioecological model is a framework that we're going to use a lot in this course. There's many different versions of this same model, and it can be tailored to different health professions. And the main concept is not exactly where different things go in this model, but just the concept that there's these different layers. So there's the individual, and then there's the people that they interact with directly, and then there's systems that they interact with directly, and then getting bigger, there's government policies, things that impact people fairly indirectly, but they're still really important. So this is just a way of looking at how much all of the different social determinants of health can influence health. And to remember that in population health, we need to be stepping back and looking at the big picture instead of just focusing on clinical care. The Minnesota Public Health Intervention Wheel is a way of looking at the different types of public health practice. And then I just wanted to put this up here to talk briefly about one of the definitions of population health is kind of a subset of public health. So we're not going to cover all of public health in this class. We're only going to cover kind of bits and pieces of it. But a lot of this content that is part of public health is actually spread across different courses that you're taking. Like 245B has policy, for example. So there's classes that you're going to take that have different parts of this that kind of builds the bigger picture, but we can't cover everything in one course. So I put this up because the public health process is actually really similar to the nursing process. And this is something we're going to use a lot as a framework in this course as well, because I know you're all familiar with the nursing process, and you can apply that same model to a bigger population. So going through assessment and diagnosis and planning and intervention and evaluation, it's really the same whether you're treating one patient clinically or whether you're looking at planning for a whole population. That way of thinking is something that you can apply to lots of different settings. It's a really versatile, helpful way of thinking. And then it's important to remember that, like I kind of alluded to earlier, the goal should be community driven and should be evidence based, not determined by hot topics or organized interest groups or crises. This should be a thought out community based process to determine what the needs are and how to address them for that community that you're trying to serve. And then I also wanted to remind everybody with this process that you always want to plan your evaluation before implementing anything. You know, whether it's on a small scale or a bigger scale, that's an important thing to always plan. How are you going to evaluate? What are the outcomes that you're going to measure to know if your program worked or didn't work? You always want to figure that out first instead of implementing and then not knowing if you actually created an effective program or not. So this was just kind of a joke because public health is a big reason why there's such a difference compared to for cavemen. I just wanted to really briefly go through some of the big public health successes. I'm not going to read through all of these, but I just wanted to point out that population health has made a tremendous impact on the lives of people in America and across the world. But I think a lot of people don't think about a lot of these interventions frequently. For example, seatbelts or occupational safety or ending child labor. Like these are all really important things that I think people often forget that they weren't always there. Yeah. Sorry, I was trying to point out that there was a lot of infectious disease a long time ago, And we don't have that happen as much anymore. We still have infectious disease, of course, it's still a problem, but we went from a time where there were these huge, terrible outbreaks of infectious disease to modern times where we have sanitation, we have vaccination, we have all of these interventions through public health development that help prevent 90% of the population from dying, or really massive things like that from happening. So like that picture up there is me getting the autograph of D.A. Henderson, who is credited with curing smallpox. So smallpox is a great example of that. It was a terrible disease, but no one in this room has ever even seen it. It's gone because of vaccination. I just want to point out that there have been a lot of changes that we often kind of forget in the normal healthcare system. All right, I'm going to hand it over to Mandy, who's going to give you a couple examples of how to implement this.
So I'm here to talk about the skills section of things. I'm going to talk about a couple of application examples of population health, because Mary has done a good job of talking about the theory behind it, right? The frameworks that we use in population health. And so I wanted to bring this home a little bit and talk a little bit about how this can be applied in the clinical setting. And I have two pretty different examples here to show you how versatile these models actually are. So the first case example that I'm going to talk about is related to tobacco use in persons that have severe mental health diagnoses in San Francisco, specifically people that are residents at Progress Foundation, which is where I have my faculty practice currently. So I'm going to talk about our tobacco tox project with this population. So it's really important to provide a little bit of context for the environment and the situation. So I'm going to do that with both examples. Progress Foundation provides residential treatment programs to people in San Francisco that have mental health diagnoses and that are in crisis. And so it has varying levels to it. And the initial level is someone comes into psych emergency services, or they come into door urgent care and they're evaluated, and then they go to potentially go to a residential program. And so Progress Foundation has several different levels of residential programs, one of them being an acute diversional unit where people are going as an alternative to hospitalization. There are also transitional programs, which are 90-day programs, and then we have year-long programs also. And so the focus of this project was really in the transitional programs and the year-long programs. There are also independent living and co-op living arrangements that Progress Foundation is also involved with. So we collected some population level data. This is all taken from nurse practitioner visits in our practice. And so basically the way we collected this was we would see a client in the residential treatment program, and then we would fill out a Qualtrics survey that talked about demographic data, talked about diagnoses that we saw, and different things. And so there's a few things that I want to point out in this data that's related to smoking and tobacco use. So one thing that we see that we know in this population is that about 90% of them are insured with Medi-Cal or Medicaid or some combination thereof. We know that about 19% are, so 70%, are the public Medi-Cal, Medicaid, and then 19% are uninsured or unknown. So that leads to about 90% falling into those either Medi-Cal, Medicare, underinsured, uninsured category. We also found that 75% of our population is without housing prior to admission to the acute diversional units or whatever setting we were seeing them in. And then we also know that there's a high rate of co-occurring substance use in this population. So when you look at smoking specifically in this population, what we found was that about 75% of our clients were using tobacco at the time. And so I'm going to talk in a couple slides about why that is such a significant health disparity. To give a little bit more background, I was going to go over the sort of common mental health diagnoses that we see and the common physical health diagnoses that we see. And so we tend to see depression Psychosis, not otherwise specified, which is sort of a blanket term for anyone that's presenting with symptoms of psychosis. And then we have schizophrenia, schizoaffective. We also see anxiety. I was going through this data and I was like, I don't know why anxiety, PTSD, and OCD are all in there together, but that's the way it is. So 10% there, and then 10% mood disorder, and then bipolar disorder also. So we're seeing a lot of depression. We're seeing a lot of psychosis, not otherwise specified, and then these other mental health diagnoses. And when we look at medical diagnoses in this population, the first thing that I think is striking is we see a lot of musculoskeletal presenting issues. And so, I mean, that makes a lot of sense when you think about the sort of most common things that people present with in primary care. That's one of the most common presenting issues is musculoskeletal. Also, this thinking about this population and the fact that they're, 75% are homeless. They don't have a lot of resources. They're at high risk on the street of injury and assault. So musculoskeletal injuries are common. And then I wanted to draw attention to respiratory and CAD specifically, because with this project, we were focusing on tobacco use, and these being directly related to tobacco use in this population. So we were seeing almost 10% respiratory. I actually think that might be a little bit low. Just anecdotally, I see a lot of people that have asthma, COPD, structural lung disease. And then we have 6%-ish that are known diagnosis of CAD. So this slide is in here to show you the disparity that this population has, right? So looking at this slide, California is actually a state with among the lowest current cigarette use in the nation. So we have, in the general population in California, about 10% of people smoke cigarettes. And in our population, 75% of people smoke cigarettes. So that is a significant disparity among people that are at progress in nation that have mental health diagnoses. And so a little bit more about why that is potentially, or what the data shows about that. And so this slide goes through what the current use of cigarettes is among people that have a mental health diagnosis versus people that don't have a mental health diagnosis. So we see that people that do have a diagnosis smoke cigarettes, use cigarettes at a much higher rate than people that do not. And so that is another example of looking at some data and comparing it and really seeing the disparity that is there. So this brings me to our framework, right? The socioecological model. And what we can do is we can use this model to help us figure out exactly what is being done about this issue and what factors are playing a role in this issue, right? And so what are some examples of some of the factors that affect this issue at the different levels? Yeah, certain types of products like menthol cigarettes being banned. Great. There's so many things. Tobacco use in general, yeah. Let's talk about what the different levels are. So what are factors at each level? What about the individual level? What are some things that factor in at the individual level? Okay, so people like smoking. It has addictive properties. It calms them down. They get pleasure from it, right? So social. So that's like getting at that interpersonal level, right? So like peer influence about smoking and family influence. So saying that the nicotine actually treats some of the symptoms associated with some mental health diagnoses like bipolar disorder. So some other examples, so at the individual level, so knowledge, right, values, attitudes about smoking, whether or not some of those individual factors are modifiable. Yeah. Yeah, and I can talk about that with the project too. That definitely came up for sure, vaping. So yeah, there's a lot of things at different levels. Organizational policies, one example of that is just like a smoke-free campus, right? Having policies at the organizational level that keep people from smoking on campus. we're going through this process, and so we kind of have a good idea right now of the data that is available to us and sort of the background of this problem. And so now we need to really further define this issue. And so what we know about this issue is that people with mental health diagnoses are more likely to smoke. We also know that they're likely to want to stop. There's data that we have qualitative studies that have been done where people that had mental health diagnoses were interviewed. Yes, a large portion of people smoked, but they also had motivation to quit. And I see this anecdotally too. Like when I talk with people, I get no's, but more times than not, I get people that do want to quit smoking. We know that primary care is an issue. So we have all these social determinants that we were talking about that are barriers to this population getting into primary care and having follow-up. And so that thus leads to a lower quality of primary care. It's hard to coordinate care also amongst different providers. We also know that they're more likely to die from smoking-related diseases. Actually, people with mental health diagnoses die on average 25 years earlier than someone without. So that's another example of a significant health disparity. So one thing that we were looking at with this is, if we could get people to think about cutting back on cigarettes, smoking, tobacco use, if we could get people to move up in their motivation to quit smoking, what impact that might have down the road. We know that evidence-based resources exist, and we know that tobacco-related death is 100% preventable. So we focused on individual measures. We focused on knowledge, attitudes, and behaviors because we were working with group education of individuals. And so we wanted to increase education on tobacco use, increase motivation to quit smoking, and decrease the number of cigarettes that were smoked per day. So that's sort of an individual thing, but I want to pop it back out to the population health perspective, right? And so what do we want that to look like at the population level? We want that to look like a decrease in cancer rates. We want it to look like a decrease in the number of people that have COPD, that have CAD, that are able to meet their functional goals, and we want to increase the years of productive life. YPPL is years of productive life lost. And now, when you go to plan your intervention, you can use the socioecological model to frame this as well. And so we are focused again on the individual level, but you can also choose to target any of these levels for your intervention, right? You could go to the policy level, you could go to an organization or a community level. And so that's why it's important to really assess all those factors that play a role in this. So that way, when you go to plan your intervention, you know exactly where you want to target. And that is dependent on the needs of your stakeholders, the needs of the community, your resources that are available also. So when we plan this intervention, you sort of like the three-step process that I'm going to go through with the other example as well is you have to recruit team members and decide on how you want to implement. You want to plan out exactly what you want your intervention to look like, and you have to plan your evaluation plan as well. So our team was made up of program directors and counselors at Progress Foundation, psych mental health and adult gero primary care NP students and faculty. And we put together sessions that were based off of a systematic review of smoking cessation interventions and different programs, different online resources. And then we evaluated with surveys at the beginning before the group started and then surveys after the groups were finished. So we also wanted to make sure to collect some qualitative data about some of the behaviors around smoking and also feedback on how the sessions were going, so that if you remember the sort of process, we want that to feed back into how we assess and plan the next round of interventions. So we did weekly group sessions. We did them over about 8 weeks. We did 8 weekly group sessions that we kept them pretty short. We kept them about 20 minutes, and we focused on a lot of different topics. So we introduced it with some of the health consequences of smoking. We talked about different strategies to cut back on smoking, techniques to help with cravings. We talked about nicotine replacement therapies. So the interventions were really we approached it with sort of more of a harm reduction idea of we really want to move the motivation of people to quit smoking, and we want them to cut back on the amount that they're smoking. But And if they quit smoking, fantastic. But when we kind of talked with clients and we talked with other stakeholders, this approach just seemed like that was what the community really wanted to do. We also had a Q&A that kind of developed a little bit organically. So like a lot of questions were coming up, and actually a lot of those questions centered around vaping. And it was actually really fun for us. It was fun for our learners because they would ask a question and I wouldn't know the answer. It's like, I have no idea what the answer to that is. We're going to go look it up and we'll come back and we'll tell you next week. And so that was something that they could ask the question and then they'd come back the next week and they get the answer to the question and we could have a discussion about it. So they actually really liked the Q&A. So this was our post-survey data on number of cigarettes smoked. What's the problem with this data? Really tiny N, yes. Yeah, I can't really, there's nothing here, right? Like this, my point is that there's nothing here. So just because you see a graph doesn't mean that it's valid information. So there's not enough here to tell us anything, right? But what it does tell us is that we need to reevaluate our evaluation plan and make sure that we're getting everyone, we're capturing everyone and increasing our N. This one was a little bit better. So we had more data points for this. I don't know that you can firmly say anything, but we did see more people a little bit higher on the motivation to quit ladder after we implemented this programming. We saw people kind of move more up into the higher levels on the ladder of the motivation to quit. And then what was really valuable was that qualitative information that we gathered about. So we got feedback on the program itself, and what we found was that what people thought was effective and people didn't think was effective. And what we found was like, we don't really need a huge lecture on health consequences of smoking. We know smoking is bad. We know it causes lung cancer. We know it kills you. We already know that. So that they found that actually to be one of the less helpful things. What they did find helpful was the strategies that we talked about to quit smoking when we actually did the worksheet that showed them why it is this. There's like a why I smoke, and it's like, is it a craving? Is it does it make you feel good? Is it a habit? Is it like the feel of it? And so like they felt that was helpful, and then there were strategies that were directly linked to those. They also did not like the walks. We tried to plan like a post-session walk with the group. So we thought, we'll have the group and then we'll all go out for like a 10-minute walk. And they were just not interested in that whatsoever. They're like, okay, we're done, bye. And we also got feedback that they found the groups to be empowering and non-judgmental. We also learned a bit about the behaviors that were associated with cigarette smoking. So one of the things that I didn't know before, and maybe some people know that work with this population, but something I learned was that it's really common practice to pick up cigarette butts from the ground and smoke them. And so because of being unable to afford cigarettes, that's what people were doing. They were picking them up off the ground when they found them. They were smoking the ends of them, and that was happening. So that was really interesting. We also found out, we talked about where cigarettes were obtained and what types of cigarettes and that thing. So getting a knowledge of sort of the behaviors of the population was really helpful too. And so this was all useful to feed back into our project, right? So then next time around we can say, okay, we know that this was helpful. We know they really liked this. Let's improve the way we're evaluating this with the data on cigarettes smoked and motivation and move forward. So we could really tailor it a little bit better to this group. Okay, acute care people. Because one of the issues so I taught this class last year with Dr. Sujung Lee, and one thing that Mary and I wanted to make sure was that we are applying this to every setting, right? This is applicable to every single setting. And so we talk a lot about community health and public health, and I think it's harder to see the applicability in acute care, but I want to run you through an example of how all of these things apply in the acute care setting and kind of get the wheels turning on how to apply everything that we talk about in this class to that setting. So before my previous life, I was an NP in the ICU. I worked at the University of Iowa in the surgical neurosciences ICU. And I was there for about 3 years after I graduated. And so, for a little context on this environment, it was a 36-bed unit, and it was trauma, anything post-op, anything neuroscience related. So that was people that were coming in with hemorrhages, that was people that were coming in with tumors, coming in with ischemic strokes. We were a level 1 trauma center, so we got traumas. It was a very busy unit with competing demands. It was a big unit, split into 4 different bays. And then we had a pretty solid interprofessional team that was involved. And so the focus of this is on what we did to address ventilator-associated pneumonia in this population. Just a little bit of background on this, and I'm going to call it VAP because it's just easier to say. So ventilator-associated pneumonia, or VAP. The mortality rate for this is 9 to 13% among people that have VAP. It also accounts for 50% of the antibiotics that are administered in the ICU setting, which is incredibly significant when we talk about antibiotic stewardship. So even if we decrease the number of ventilator-associated pneumonias, that's great for mortality, but it's also good for antibiotic resistance. The direct cost of a VAP is anywhere from $11,000 to $25,000 for one infection, which is really significant because we know, well, we'll talk about it with the model in a second. So in the SNCU in Iowa, the surgical ICU in Iowa, we had about, on average of our 36 beds, 3 ventilator-associated pneumonias per month, and this was back in 2010, 2011. And so that meant that our direct costs every single month, just from these infections, were $35,000 to $75,000 a month. That was like my salary every month. What we did was we went upstream, right? So how do we prevent ventilator-associated pneumonia from happening? We get the breathing tube out. We take the ventilator off. So what we were looking at was, what are the barriers to doing that? What we found was that there were patients that met criteria to get the breathing tube out, but they were getting delayed. And so why was that? And so we did a lot of interviewing and talked with people and sort of did like an assessment of the situation. And we found that oversedation, especially at night, was an issue. So the sedation gets turned up at night. The ventilator settings go up because now the patient's not breathing as much. Busy schedules definitely played a role. So coordinating between nursing, respiratory therapy, the medicine team, everyone. Also the risks of taking the breathing tube out. So the risk of having to put it back in. Is there an experienced person available to put that breathing tube back in if we take it out and the person fails? And that relates directly to inexperience, because sometimes patients would come back from the operating room, for example, at 6 p.m. All the attendings had gone home. We didn't really have a lot of anesthesia coverage at night. And so the intern that's on in the bay is saying, I'm just going to leave this person. I'm just going to leave the breathing tube until tomorrow morning. And then we're waiting till after rounds the next morning, adding hours of ventilator time to the patient. So back to the socioecological model, because we can apply it in any situation. What are the factors that play a role in this at the individual level? So I look at this. This is like one of those things where it's like you could like argue like different ways, right? I look at it as sort of like the individual characteristics of the person that is getting the ventilator-associated pneumonia, and I would put that in the interpersonal sort of patient-provider interaction sort of interpersonal space. But you could say at the individual level, knowledge of a person that is taking care of the patient and whether or not they're comfortable. So the nurse and the nurse's knowledge and the nurse being empowered to advocate for getting that tube out.
Why everyone's overworked and why everyone's schedules are stuck because they can't.
Great, thank you. Going even further to the root of the problem is, why are we so busy all the time, and why can't we assess this really important thing? Yeah, so is there a VAP protocol in place, right? Yeah, back. Yeah, so at the individual level, what comorbidities are there? Do they have underlying lung disease that's making this really hard, or cardiovascular disease? Do they have a neuro injury? So our patients, we have a lot of neurologic injuries in our patient population. So that can, in order to get the breathing tube out, you have to be awake enough to follow commands, to protect your airway, to make sure that your tongue's not going to fall back and occlude your airway. You have to be able to breathe on your own, and you have to sort of, you have to be strong enough, essentially. Yeah. That's a good question. I guess I would say maybe like interpersonal or individual for that, depending on, so like if it's interpersonal, the parent interacting with the care team and advocating or not, or their knowledge level and being educated on that. Yeah, I would put that maybe at the interpersonal level. That's good. Family, parents. Yeah. So great. Thank you. That was a good discussion of the different factors that play a role in this. So we've assessed this, and we know that we have an unruly VAP rate on our unit. We know that the costs to our unit are high. We know that our patients are at increased risk for VAP. We know that there are barriers to sedation weaning, getting the sedation off, and we know that there are barriers to extubation, but they could potentially be modified. And then we know that ventilator-associated pneumonia is a preventable thing, right? And the one thing that didn't come up here in terms of this being a preventable issue is at the policy level, what's going on? Implementation of spontaneous awakening and spontaneous breathing trial. That I'm going to put in the organizational, because that's like your unit or your healthcare facility implementing that policy. That's a policy level, right? And that's exactly what we did. So I'm going to get into that. Yeah. You don't get reimbursed for this anymore, right? So there's super incentive to prevent these things. So that is something that's happening at the policy level that is affecting what we're doing on the ground. So what we decided to focus on was something really easy. We were already collecting data on the number of VAPs we had every month, so we continued to look at that data. And then we also wanted to look at the interprofessional team and how our coordination was playing out. And we had respiratory therapists that were sort of the primary management of our ventilators. And so event changes were made. Scope of practice is a little different in Iowa. So the order would come from an MD, an NP, or a PA to change the ventilator settings. And the RT would then go change the ventilator settings. The nurse adjusts the sedation. The nurses on our unit didn't really touch the ventilators, which I think is different than some other ICUs, especially I think in medical ICUs, it tends to be very nurse driven. So we had our RTs there that were only really able to do anything if they had an order from the provider. And so when you think about that in terms of whose expertise is where, the RT has all this expertise in ventilator management, and they have to go to this family medicine intern that's on overnight to be like, hey, can we change the ventilator settings on this person? And the family medicine person's like, yeah, okay, like, oh, sure. So when you think about where people's expertise was, we really needed to refocus that. And that's essentially what we did with this project. So we focused on the interpersonal and organizational levels, and we wanted to focus on improving coordination of the interprofessional team. We wanted to implement any policies, new procedures that needed to be implemented. And we wanted to basically just educate people on this issue as well. So we decided that we were going to use, and people in acute care are probably familiar with this, and this was also 2011, 2012, so no promises that this is the most evidence-based thing at this point in time, but we decided to use Vanderbilt's Awake, Breathing, Coordination, Delirium, Early Mobilization bundle. So we were implementing a VAP bundle. And so basically what this is you coordinate waking the patient up. So you turn the sedation off, you coordinate that with a spontaneous breathing trial where you make the ventilator, essentially give them a little support, but the patient's doing it all on their own. So they're awake and the ventilator is still in, but there's not a rate for them. They're initiating every single breath. And then we're working on coordinating that happening. So what's the issue with that? Busy schedule, staff availability. So you can't just do that. You can't just turn the sedation down and then walk away, right? You have to stay with them there, because the first thing they're going to do is yank the tube out. So we had to educate, and we had to talk about basically the importance of these trials. And educate and talk about how we were going to have RT and nursing work together to make this happen. And one of the things that we decided to do was to change our sedation policy. So we changed our sedation policies. We changed our ventilator weaning policies to give respiratory therapy a little more autonomy. So if a patient met all of these specific criteria, they could initiate the pressure support trial. They could initiate that really low vent setting for the patient and try it. And then if anything happened out of the ordinary, the patient immediately went back to the previous vent. So it's sort of like an increase in respiratory therapy's ability to assess and evaluate the patient for extubation. We also implemented a new delirium and early mobilization protocol for patients. What we did initially was we piloted this in one of the bays just to kind of like, we have no idea how this is going to go. Let's not roll it out to 36 beds. Let's focus on 10 and then see how it goes. And so then we rolled it out to the rest of the unit after that. And so our evaluation plan was really already in place. We were collecting VAP data as we went, one. And two, we were talking with RTs and nurses and other interprofessional team members along the way. And I will say that the other thing that we did with this is that this was truly an interprofessional effort. So for the early mobilization protocol, for instance, when we formed our team, our planning team, we decided that physical therapy, you are going to take the lead on this protocol because this is your area of expertise. Pharmacy, you're going to take the lead on the sedation changes to our sedation protocol. And so like we really used everyone's expertise where they were. Nurses were involved, I think, in every team, but really took the lead on the delirium and the early mobilization protocols for the patients too. But yeah, nursing was definitely, I think, highly involved with every aspect of this. We also put together some algorithms for these as bedside resources. That's another thing that we did. This was like a months of planning and huge quality improvement project that we did. And then we also had unit education champions that actually went around and provided group education and then one-on-one education on these different things to residents and to bedside nurses. And so what we saw as a result of this was that our VAP rates significantly decreased over time. We went from having essentially 3 VAPs every month to 1 every 3 months. What that calculates out to is a cost savings estimated at about $300,000 over 6 months. So this was a significant change, and it was a really difficult project to plan and implement, but it certainly had an impact on this population. We also, in terms of evaluating, so we looked at VAP rates, right, but we also talked to our team and really got an idea of how things changed. And so what we heard from our respiratory therapists was that predominantly they were talking with nursing more, they were coordinating more. They felt like it was making the whole healthcare team more aware of how important it was to get people off the ventilator. And then actually as a result of this, we previously had this sort of typical medicine team rounds there, they just like get the computer and go around and like hit everything and then move on. But this actually made us have multidisciplinary rounds. So multidisciplinary rounds actually grew out of this project. And I'm going to hand it back over to Mary here in a second. But the point of this was to illustrate this process and how applicable it is to any setting, no matter what setting you work in as a clinician. And you're going to be taking care of individuals, but you're also going to be taking care of panels. You're going to be taking care of populations. And so that's why this is so incredibly important and why we will frame everything in the greater model of the socioecological framework, because we as healthcare providers really only have an impact on a very specific amount of the actual impact on health outcomes. So let's do a 5-minute break and then we'll dive into some fun stuff after that.
I'm not going to have time to get through all this today. That's the plan. So I'm just going to go until I run out of time, and then we'll pick up wherever we left off in a week. With this course, the idea is to give you guys tools that you can use in the future wherever your careers take you. So we're trying to focus on concepts that can be applied in a lot of different settings. I know a lot of this content was covered to some degree in research, and you're going to need to use some of what you've already learned in research and other courses in order to apply this. So I'm not going to completely go into everything if I know that something was already covered in research, but this is a little bit different because we're looking at specifically population health application of these concepts. I wanted to start with a couple questions. Unfortunately, Poll Everywhere is not working right now. So I have questions built into the rest of this presentation. Some of them are multiple choice, some of them are more discussion questions. So if you guys will kind of play along, I can't use Poll Everywhere. So the first one, do you guys want to read that? How many people think it's false? Okay, good. So that's actually a really common error. There's been a lot of research actually looking at physicians answering a lot of these questions, and a lot of physicians get that wrong. So that's why I put that in there, because it's a really common error that people make. And then the second one, your hint is it's not hard math. You shouldn't need to write anything down. Okay, so I heard a 40%. Any other? 4, yeah, so 4 is the correct answer. So positive predictive value is the proportion with a positive test that actually has the disease. So if 9 out of 10 positive test results are correct, which are true positives, then the positive predictive value would be 90%. So the positive predictive value describes how likely it is that a positive test result in a given patient population represents a true positive. And we'll get into that more in a second. Epidemiology is the study of the distribution of disease and the factors that determine that distribution. So it's the study of the distribution of determinants of health and disease in human populations to enable health services to be planned rationally, disease surveillance to be carried out, and preventive and control programs to be implemented and evaluated. These concepts are something that you as a clinician will use, even if you're not actually working as an epidemiologist. Because a lot of this can be used in clinical settings and in program planning if you're working at the community level. This diagram is just kind of a rough way of looking at, if you have a population of people, the people that have a condition are a subset of that, and then the people that actually seek medical care for a condition are an even smaller group. And then the people that you see in the hospital are an even smaller group within that. So it's important if you work in acute care and patient settings to always be thinking about how many people are out there in the community who you're not seeing for every one person you have there in a hospital bed. Because there's often a big part of the population that you don't see as a clinician, even though they're still affected by these same factors and same conditions. And then the people who die is spread across that. I'll get into mortality rate a little more next week. The natural history of disease is really important to understand. Today we're going to talk about screening, and it's important to have what's known as lead time. You need to have a detectable preclinical phase, so something between the biological onset of disease and diagnosis, where you can detect that the disease is present, but it's early enough that an intervention at that point will still change the outcome for that patient. That's necessary for screening to make sense. So we'll come back to this a little bit more later, but it's good to just keep in mind that we're talking about all these things in the context of knowing the natural history of the diseases which we're screening for. This is a really important slide, and the article that this comes from is actually really great, even though it was written in 1968. This should be used as a framework for any screening program. So the condition should be an important health problem. It should be something that is a serious health problem for the individual, for example. And there should be an accepted treatment for patients with recognized disease. So, for example, you wouldn't want to screen for something if we don't have a treatment that works for that condition. And then I have a question for you guys related to this list. If a group of students travel to a remote village in Uganda to screen locals for lung cancer during their spring break, why might that be unethical?
You're only there for a week.
Yeah, okay. What else? Okay, so we've got, it's short duration. You're only there for a week, so that's a problem. Yeah, so there's no follow-up if you do that. What else? There's a reason why I picked a remote village in Uganda as this example. It's a hint. Yeah, resources. So one of the big ethical concerns to always keep in mind with screening programs is you need to be 100% sure before you implement any sort of screening is that the person you're screening or the population you're screening has access to treatment for that condition, has the resources to treatment and the follow-up. So yeah, there's several problems with that example. So for any screening program, you need to make sure that it's a sustainable situation. So it's not 1 week duration and then you never come back. It needs to be an ongoing thing, not a one-time intervention. And then you need to make sure that you can follow up with all of those patients to make sure that they actually receive care, because you don't want to ever screen someone and give them a positive test result and then just like walk away. Like that would be really unethical. But that does sometimes happen. So it's a really important point to always remember. Health outcomes is often how we're going to measure population health. Incidence is the number of new disease cases. Incidence rate is the rate at which cases are occurring. So incidence rate per 1,000 would be the number of new cases during a specified time interval divided by the number of people at risk during that time interval times 1,000. So an important thing to point out about that is your denominator in that fraction is the number of people at risk during that time interval, not the total population. That's a good point to remember. And then cumulative incidence is the risk for developing the disease over a specified time period. And then person time is how long you're monitoring people for development of the disease. A lot of studies use person time in the denominator. So if you have a study, like if let's say you have 10 people and it's a 1-year study, then you have 10 person years, because if you're following all those people for that whole year, you have 10 person years of time for which you're monitoring each of those people in your study to see if they develop the condition. Here's a question related to that. So if 20% of the participants enrolled in a study are lost to follow-up by the time the study ends, how will this affect person time? Yeah, it'll decrease, yeah. So that's a good thing to keep in mind, because a lot of studies that does happen. So it's always important to think of what is your denominator and is it different from what it was at the outset. Prevalence per 1,000 population is number of cases present in the population at a specified time divided by number of people in the population at that time times 1,000. So in that one, compared to on the last slide, it's number of people in the population at that time, regardless of if they are at risk or if they have the condition, doesn't matter. All those people are in the denominator. You'll hear of point prevalence and then also period prevalence sometimes. If you hear someone say prevalence and they don't specify which one it is, it's usually point prevalence. And then period prevalence will usually specify the time frame that it's referring to. So like over 12 months as an example. Another question for you guys, is prevalence a rate? Okay, I saw one answer. Anybody else? This is a common mistake again. Okay, yeah. So it's a proportion. So this is saying a lot of the time you hear people say prevalence rate and it gets confusing. So incidence rate is a rate because it has time in the denominator, but prevalence does not. So a proportion is division of two numbers where the numerator is a subset of the denominator. So the people affected over the total population. A rate is a proportion where time is always the denominator. So like events with population time, like we were just talking about, as the denominator. Okay, so I know there's a lot on this slide, but if you look at this, I made it so each of the blue dots is representing a person, and then the purple horizontal lines are representing the time period for which that person had the disease. Can anybody tell me what the point prevalence in 2017 would be? I'm hearing some people say 3. Any other answers? Okay, so partially correct. So yeah, you have 3 people in 2017 who have the condition at that point in time. And then your denominator for that one, because its prevalence, is the total population. So it's 3 out of 10, and then you usually would be multiplying by 1,000. So that's your answer overall. And then what about period prevalence from 2016 to 2020? So looking at this whole time frame on the slide, what's the period prevalence? Someone said 500. Any other answers? So yeah, that's correct. Does anyone want to explain how they came to that answer in case anybody didn't get it? So you have 5 people who had the condition within that period of time. That's why that's your numerator. And then the denominator is 10, similar to point prevalence, because it's a prevalence. So it's looking at the total population as the denominator. And then incidence rate in 2018, what do you guys think? Okay, 300, anybody else? Someone said 30%. Any other answers? Okay, so incidence rate, remember that was a little tricky because incidence rate or denominator change, right? So incidence rate in 2018, how many new cases happened in 2018? Just one, right? So it's a little tricky because we have 1 new case in 2018. How many people in 2018 were at risk of developing the disease? It's only 8, right? Because these 2 people down here, they already have the disease. They can't develop the disease in 2018, right? So you have to take them out of the denominator. So you end up with 1 divided by 8 instead of divided by 10. Does that make sense? All right, and then what about cumulative incidence, 2018 to 2020? Question? Yep.
Instead of assuming they can get the disease again.
I was assuming that if you have the disease, you are no longer at risk for the disease. So that's usually the case. For example, like, if you get this illness and you have it, if you're still a purple line, then you can't get it again. Like, you've already caught it, you have it. So you're no longer at risk for acquiring the disease. Oh, sorry, I see what you're saying. Yeah, okay. So if it is the case that you can't reacquire it again, then it would be 1 out of 7. But if it's a disease, like let's say it's the seasonal flu, then this would be correct because you get it in a subsequent year so long as you don't currently have the condition. So it depends on the condition. And then cumulative incidence, 2018 to 2020. I heard 25%. Any other? Sub 1? 50? Okay, 2050. This one, you have 2 out of 8. So cumulative incidence, 2018 to 2020. So you're only looking at that time period. And then you have 1, 2 new cases. And then we're going with seasonal influenza on this one. So assuming that even this person over here that had it back in 2016 is at risk for getting it again, then you would end up with 2 out of 8, so 25%. This is showing, if you look at a population, how incidence relates to prevalence and the duration of disease. So the formula in the corner there is point prevalence is equal to incidence times average duration of the disease. So as incidence is increasing, like they're pouring more liquid in, your prevalence is going to increase. And then as people either die or are cured, that's going to bring the level down. Yeah. So it depends on if you're looking at incidence or prevalence. So if we're looking at one of the places where there's a green line and the person is currently a purple line, then that would be yes for prevalence, but no for incidence. Because prevalence is looking at how many people have the condition at that point in time, whereas incidence is looking at new cases only. So if you already have it, you don't count as incidence because it's not a new case. It's a prevalent case. Does that make sense? So I just wanted to put this up there just as a kind of concept to be thinking about, that for each disease, this is going to look a little different. So for a really short disease like seasonal flu, this is really different from if we're looking at something that lasts a lot longer. And your prevalence is constantly changing as incidence changes and people either die or is cured. So all this is dynamic. That was point prevalence is equal to incidence times average duration. Oh, and another thing I should have mentioned, you guys don't have to memorize any equations for this course. So I'm going through math because I think that it can help you really understand the concepts better, to actually work through it and really think about it and challenge yourself to make sure that you really understand it. But this isn't actually a math class. So if there's ever a calculation of any kind, I'm always going to give you the formula. So you don't have to memorize any formulas.
If you look at population health data source and they give you an incident rate, you're going to know exactly what that means.
Yes, and that's what's really important. So you don't have to be like an expert in this, but knowing enough to, like, if you see a number where it says that it's like 40% and you're like looking at it thinking, wait a minute, I think that's supposed to be 4%. that's kind of the, you don't have to be exact with any of this, but you should know enough when you're reading an article to catch big errors. Like if someone misinterprets one of these terms and applies it improperly, to question that and be like, oh, I think that they used that incorrectly. Does that make sense? So there's 3 levels of prevention. Primary prevention is avoidance of illness through health promotion activities and protective actions like nutrition, hygiene, immunization are some examples. Health promotion, the goal is to enhance well-being by empowering individuals to improve their health. And it recognizes that health is multidimensional and some factors are outside of an individual's control. And it's based in principles of equity, social justice, and health for all. And secondary prevention is early disease detection and screening. And we're going to go into that a little bit more depth after this. And then tertiary prevention is working on limiting disability and rehabilitating people who already have a disease. So that's another thing that's important to just keep in mind of these different levels. It's good to just have an idea of which level you're working at any given time, because things are a little different depending on what level of prevention you're doing. Secondary prevention is mostly screening. The benefits of screening are early detection and treatment of disease. And then screening does have risks. So false positive test results can lead to stress for the person, and they may end up getting unnecessary tests or other procedures after that positive test result. There can be side effects like radiation from tests. There can be ethical concerns like we talked a little bit about already. And a good test should be easy to administer, inexpensive, cause minimal discomfort, and it should be valid and reliable. And then I mentioned with the slide where I had the natural history of disease, you have to know the natural history of the disease you're screening for in order to determine if it has a detectable preclinical phase where you could do a screening program and then change the outcome for the people. Anybody want to read this one? Secondary. Any other answers? So in this example, you're working with people who have diabetes, right? So they already have the condition. So it's actually tertiary is the correct answer. It's not secondary because they already have been diagnosed with the condition. This program is working on helping people who already have the condition live healthier lives following diagnosis. It isn't a screening program is the second part of this. So it's not screening if the person has already been diagnosed, right? And that can be important when we're looking more at testing, because how you interpret tests is different depending on if it's a screening test versus a diagnostic test. So screening tests and diagnostic tests are sometimes the exact same test. You're placed in the same order to the lab, but how you interpret those results is different, whether it's a screening or a diagnostic test. Validity is how good the test is at separating out the people who have the condition from the people who don't. And reliability is getting the same result with repeated measurement. So what we're going to go through, I'm sure you guys have seen the 2x2 tables before for sensitivity and specificity. And I just wanted to remind everybody that this is sort of a artificial way of looking at things. It's helpful for learning these concepts to put things in the 2x2 tables. But oftentimes in practice, the situation you're in isn't exactly how these examples usually are taught. So a gold standard is the best available test, which can be used to compare with a new test. So an example we're going to go through is if you have the gold standard test and you're trying to figure out if this new test is as good. So that could happen in practice, but that's not the most common example, because like how often are you trying out a new test? Probably not that often, right? So it's helpful, but this isn't like always how you're going to apply these concepts with the beginning of this. Sensitivity is the ability to correctly identify the people who have the disease, and then specificity is the ability to correctly identify the people who do not have the disease. So sensitivity shows how well the test performs in people who have the disease, while specificity shows how well the test performs in people who don't have the disease. And then for screening programs, this isn't always the case, but generally we're going to want a program with a higher sensitivity compared to specificity, because we want to catch all the people in the community that are positive for the disease, even if that means catching a lot of people that actually don't have the disease, because then we're going to follow up because it's a screening program, right? It's not a diagnostic program. So that's a key difference. Okay, running out of time. I'll try to do this one last slide. So true positives are the people who test positive and also have the disease. And then false positives are people who test positive but do not have the disease. And true negatives test negative and they do not have the disease. And then false negatives test negative, but they actually do have the disease. So if you had an ideal test in a perfect world, all of your people would fall in these two boxes, right? But no test is perfect. So we always have some false positives and some false negatives with any test. So that's how you calculate sensitivity and specificity. So for sensitivity, you're looking at the true positives, so the people that tested positive and actually have the disease, divided by the people with the disease. So the reason why I shaded it blue on that side is because with sensitivity and specificity, you're looking vertically for your denominator. So that's to remind you that when you're dealing with specificity and sensitivity, you're looking up and down to get your denominator values. But that's not always the case. That's why I color-coded it. And then this is useful when you're looking at a test with dichotomous results. So for example, if you're screening for something where it's like you either have the condition or you don't, that's where this can be helpful. If it's not something with dichotomous results, this isn't really applicable. So this doesn't apply to everything. All right, so I guess I'll end here and pick up next week. And then after next week, I'll make a non-graded homework assignment. So I'll put up some practice problems and practice examples, not graded, but that way you can go through on your own. And I'll also put up an answer key. So you can study on your own, check your own work, and see if you're getting it or if you need to study something more or follow up more.
Also, think about the tests that you use in your clinical environments and how this can be applied to those too.